the next speaker, Dr. Christine Dickerson. She's an assistant professor from College of Nursing. Her research has been focused on the genetics and the mitochondrial profiles on cancer-related fatigue. So let's hear the talk on radiation-related fatigue.
Thank you to the organizers and committee for the opportunity to present today. And what better time to talk about fatigue than Sunday afternoon at 4:30. So I have no conflict of interest to disclose, and I'm going to talk today about what radiation-related fatigue is and what ongoing efforts we are engaged in to better understand this symptom. So a symptom is commonly conceptualized as an individual's self-reported experience with disease or the supportive care needs resulting from disease and the treatment of the disease. These supportive care needs can range from physical, cognitive, emotional, psychological, social, spiritual, informational, and practical domains of need. And all of these domains of need can greatly impact disease management and health-related quality of life. Symptom science is the optimization of the assessment and management of symptoms to improve health and health-related quality of life. So my program of research is currently focused on fatigue, and I'll address today establishing the best practice for assessment of fatigue, understanding the biologic correlates of fatigue, and how we're going to use that information to develop tailored interventions for management. So this work is guided by the National Institute of Health Symptom Science model. And as I move through my presentation today, we'll kind of go through this model as a guide for the presentation of my research. So we'll start with the complex symptoms. So why are we interested in fatigue? Fatigue is a very pervasive and common symptom. It's consistent across multiple chronic conditions. But for cancer specifically, fatigue is often the most common and distressing symptom reported by cancer patients. The National Comprehensive Cancer Network defines fatigue as a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. The true prevalence of fatigue is hard to define, but it is very common at diagnosis, with up to 40% of patients reporting fatigue. The majority of patients will experience some degree of fatigue during active treatment, with those prevalence rates ranging from 80 to 90% of patients reporting fatigue during treatment, and up to a third of patients can experience fatigue in the months to years after treatment completion. Fatigue is not only very common, it is a very challenging symptom due to our lack of understanding of what causes fatigue. What we do know is that patients often describe their fatigue as weakness, limb heaviness, and reduced energy. Fatigue is a very challenging symptom. Let me go back. Fatigue is a very challenging symptom to assess. From a patient standpoint, they often do not report experiencing fatigue to their healthcare providers. And this can occur for a number of reasons. Patients don't want to be seen as complaining. A lot of cancer patients feel lucky to even be alive, so they kind of put symptoms to the back of their mind. Others see fatigue as something that's expected. They're expected to experience treatment symptoms during treatment. And I've had patients tell me, well, I'm feeling fatigued, so my treatment must be working. I've also had patients tell me, well, I'm not experiencing fatigue, so something must not be working with my treatment. So these misconceptions about fatigue and other symptoms contribute to fatigue being underassessed and undermanaged in the clinical setting. From a provider standpoint, it's very challenging for us because we don't have an objective measure of fatigue. There is no test I can give my patients to tell them you're fatigued or that tell me that they're fatigued. What we're stuck with is subjective assessment. So we have participants self-report, and there are a multitude of assessment options for that, including single item fatigue measures such as a numeric rating scale or a visual analog scale. These are quick and easy to administer, but they often lack detail. There are multi-item unidimensional scales, which are also generally short, but limited to just telling us about intensity, severity, or interference of fatigue. And then there are multi-item, multi-dimensional questionnaires. which tell us a great deal about fatigue, but they are lengthy and difficult to score, making them not very practical for use in a clinical setting. So one of our efforts that we have ongoing right now is the development of a tool to assess the multidimensionality of CRF in a clinical setting. And we developed this tool in combination with our collaborators from PROMIS. We used the PROMIS item fatigue bank to develop this questionnaire. The core questionnaire has 5 questions. On top is the numeric rating scale as provided as guidance from the NCCN, followed by the core questions. And then our last question asks about what aspect of fatigue bothers you the most. And we're hoping that a questionnaire like this can help clinicians and researchers guide to individualized tailored management for fatigue in the clinical setting. So right now, our goal is to enroll 200 adult patients diagnosed with cancer. We have 90 enrolled right now. And then in addition to getting data on the reliability and usefulness of this tool, we are collecting sociodemographic information on all 200 of these patients, and we're hoping to see if we can determine sociodemographic correlates that can play a role in the fatigue experienced by these patients. So on to the biomarker discovery. So limited understanding of the etiology of fatigue has precluded the development of both biologically based detection methods to determine those at risk for symptom occurrence, as well as tailored interventions for management of fatigue. So we have 2 models. We have a clinical model and a preclinical model. And we use those patient descriptors of fatigue being reduced energy, muscle weakness, limb heaviness, to guide our, to drive our biological investigations. So most of my work has looked at metabolic signatures that might contribute to cancer-related fatigue. So I will go into, so the first is our clinical study. We are working with men with prostate cancer who are scheduled to receive external beam radiation therapy. We follow these men for 6 study visits over 2 years. We see them before they start treatment, midpoint of treatment, completion of treatment, and then 6 months, 1 year, and 2 years after treatment completion. And then at each study visit, we do the exact same thing. We have a set of self-report questionnaires, and we collect blood. The self-report questionnaires that we collect assess for fatigue, but they also assess anxiety, depression, physical activity. We do a broad symptom inventory, and we look at prostate-specific quality of life through the EPIC-CP, as well as global quality of life. And then the blood that we collect is used to evaluate the transcriptome profiles. We're doing RNA sequencing, and we use blood for assessment of the mitochondrial bioenergetic profile through the Seahorse cell mitostress test. And we recently just initiated this preclinical mouse model. And I'm really excited about this work because it'll enhance our access to tissues that that are pretty much unavailable to us in the clinical setting for these explorations. So what we're going to be doing with this model is mice will be implanted with prostate tumor cells. They'll be randomized to receive androgen deprivation therapy or radiation. And after completion of treatment, they will be placed in individual cages equipped with running wheels. And the running wheel activity will be recorded, and that will be our surrogate for fatigue for these animals. And then we'll allow them to run for 2 weeks. And then after the 2 weeks, we will collect tissues for an array of metabolic investigation, including looking at mitochondrial markers of structure and function, oxidative stress, hypoxia, and metabolomics. And this model will be useful to complement what we are studying in our human model, so that our clinical can help drive our preclinical, and our preclinical can help drive our clinical investigations into understanding what causes fatigue. And then where do we go from here? So moving forward with our biobehavioral approach, we hope that our preclinical and clinical models will provide biologic correlates that can be used for risk assessment. If we can identify those who might be at risk for fatigue, then we can provide early intervention and management. or those biologic markers might provide targets for intervention, whether that be pharmacologic or non-pharmacologic intervention that we can use. And then from the behavioral aspect of biobehavioral, we have several projects right now in collaboration with the University of Nebraska at Omaha, developing e-health interventions where we can assess and provide tailored management through websites for patients for the management of their fatigue. So kind of to sum up, we've started with our complex symptom of fatigue. We've identified that it's a burdensome symptom. We're working on ways to assess it in the clinical setting, to characterize it. Once we can characterize and determine that someone has fatigue, we're working to determine what causes fatigue. And then once we can better understand what causes fatigue, then we can start to tackle it in a clinical and mitigate that symptom for a clinical setting. And I believe that's all I have. And I also just want to, in conclusion and wrapping up, just want to thank all of my collaborators and colleagues, many of whom are in this room today, for all of your support of this research and this emerging program. Without you, none of this would be possible. So thank you very much.